Well, thanks very much. I think Mark has obviously done his usual outstanding job at setting the stage and providing, I think, an exciting backdrop against which we can place our clinical data and try to then take the next steps forward. So Luca was to talk about triple-negative breast cancer as an unmet medical need, and the goal here is to focus on what we do know about available and some experimental agents in triple-negative breast cancer, and in particular some of the limitations that we really have to overcome in the next few years if we're going to make any significant strides here. So my talk is going to range over a broad array of, I hope, clinically relevant topics, and setting the stage for some of the advances that you'll hear about in the following two talks. This again just reintroduces the idea that we're talking about a specific subset of breast cancers, but that there are overlaps between what we call basal-like breast cancer as well as what we call triple-negative breast cancer. And this is going to come back to haunt us during my talk more times than I remember to note, because the clinical data that I show you will, in various places, have been defined on the basis of basal-like breast cancer phenotype or based upon a triple-negative phenotype. Just backing up a little bit and setting the stage from the purely clinical point of view, some of the questions that you'll have will concern the epidemiology and the risk factors for triple-negative breast cancer, and these are summarized in a very superficial fashion here. First of all, there is a greater rate of triple negativity in women who are younger. This may be conflated by the likelihood of BRCA1 expression when it's present in those young patients in the phenotype of breast cancer. There's an association, as you've already heard indirectly from Mark, between triple-negative phenotypes and African or Hispanic ancestry, but I have a big caution here, and I don't know that this story is completely unraveled, but Otis Browley from the American Cancer Society, when he talks about healthcare disparities, makes a really, I think, sobering point. If you go to Scotland with a homogeneous patient population and you stratify the population purely on the basis of socioeconomics, you discover a greater rate of triple-negative breast cancer in the lower income social groups. And so, at least in the United States, there is a serious risk of, again, conflating African American ancestry and lower socioeconomic status. And this could mislead us as we go forward in our work. So said another way, one has to be, I think, somewhat skeptical of a few superficial phenotypic characteristics in genes being associated globally with a specific subtype of a malignancy like breast cancer. So I would just continue to think very critically about presentations on this issue. A lower proportion of triple-negative breast cancers are discovered by mammography, but that again is in part related to the age distribution of these patients. And there are a bunch of other potential risk factors at the bottom, excluding the known one, which is BRCA1 mutation status. And all of these, when one looks at epidemiologic data, end up with less than 2.0 relative risks. And from an epidemiologic perspective, they therefore have to be taken as modest risk factors, if at all. Said one other way, none of this actually allows you to do very much differently about the triple-negative breast cancer. The second issue is that it is, from a purely histologic point of view, still a collection of subtypes, with some, like the secretory or adenoid cystics, being relatively less malignant, even though they are triple-negative. And the one circled on the bottom right is really what you're thinking about most of the time, and that is high-grade invasive duct carcinoma without ERPR or HER2. The natural history of triple-negative breast cancer has been defined and redefined over the last few years multiple times. It's actually remarkable how many different clinical data sets provide the same basic curve. This one's shown from Kim et al. Simply because it's the most recent, but we have shown this for years, if not decades, in earlier clinical trial data sets. Fundamentally, in the early stage setting, triple-negative breast cancer is associated with earlier versus later events, and, as I'll show you in a moment, from the time of recurrence until death, a shorter period. In addition to that, it's associated with a different distribution of metastases. The luminal A metastatic breast cancer, as you know, causes late bone metastases, and these tumors, triple negative, cause early visceral metastases. This pattern is not news. It's been around forever. Interestingly, though, the overall rate of relapse over the decades for these two types ends up being more or less the same. It's just the distribution over time. So the metastatic potential ultimately is the same, but the growth rates and tumor distributions are what vary. As I mentioned, once there is metastatic triple-negative breast cancer, there's a much shorter median time from relapse to death, and this, of course, represents a key challenge as we try to palliate an incurable disease. There are the usual list of potential poor prognostic markers. I, again, would caution you against making too much of this. These factors come up in any series of metastatic breast cancers, and some of them are not particularly well categorized. For example, to pick on just one, there is no agreement still on a standard assay or expression levels for EGFR, and yet this will be listed as a poor prognostic factor. In a relative sense, I suppose that's true, but as a practical matter, I don't know how it helps us. So I want to move forward now and talk about the limitations on our current treatment strategies, and I'm going to highlight a couple of aspects. First, I'm going to focus on some conventional drugs as well as some newer ones. I'm going to revisit the platinum story, not to disagree with Mark at all, quite the opposite, but to highlight the challenges in teasing out the story when we fail to narrowly define the group that we're studying. And I'm going to highlight one other important recurring paradox, which is that these tumors typically have higher response rates to various agents that we use, and yet poorer outcome. And this challenges, from a drug approval or regulatory perspective, the role of the surrogates that we widely accept, like progression-free survival. So let's start with anthracyclines and taxanes. The first story, which is fairly simple to describe, is that these regimens, either TFAC, the MD Anderson type approach, or ACT, the intergroup NSABP type approach, in relatively small series of patients treated in the preoperative setting, are effective. What you see is in the triple-negative breast cancers, as opposed to especially the luminal A's or B's, there's a markedly higher response rate. In addition, though, and despite that higher response rate, this is that paradox, this subtype has a far shorter disease-free and overall survival. So one has to be very, very critically clear in their thinking when one talks about using in-breast response as a surrogate for outcomes. There's no doubt that in a defined subset, an in-breast response yields a better disease-free and overall survival. But if you don't select your patient population appropriately, you can end up with this paradox of high in-breast activity and worse overall outcomes compared to other groups. A much larger TFAC series shown here, over 1,000 patients, compared or allowed these investigators to compare the triple negatives on your left with the non-triple negatives on your right, a doubling of the PATH CR rate, but a shortening, as I just described, of both progression-free and overall survival. So this paradox will plague us with these drugs. There's been one meta-analysis by Angelo DeLeo, who's here at this meeting, and several smaller phase 2 and remarkably small, but nonetheless randomized phase 3 trials with anthracyclines. And the message here, I think, is a little bit difficult to tease out. The first pass, one can say that these drugs have activity in triple-negative breast cancer, but their relative merit compared to other available agents I don't think can be addressed. Focusing on the taxanes, Dan Hayes, now at SWOG but formerly at the CLGB, retrospectively studied the subset of patients in the CLGB 9344 for whom we had paraffin. And he broke these patients into 4 groups shown here. Critically, the largest group on your upper right is the HER2-negative ER-positive cohort. And despite the overall positivity of 9344 for the addition of the taxane to AC, that subgroup appears not to get a large benefit. I say this very guardedly as one of the co-authors of this. This is not a consistent finding across all trials. The GuyCam data isn't precisely consistent with this as well. However, I draw your attention now to the ER-negative column on your left and the upper left-hand box. That's HER2-negative and ER-negative. That is the triple-negative cohort. And in that group, there is a large benefit for paclitaxel. This data and others is consistent with the hypothesis that the taxanes are useful in triple-negative breast cancer. They are also useful, as shown on the bottom two panels, in HER2-positive breast cancer, regardless of receptor status, in the pre-trastuzumab era. And then we have several other data sets. This is the BCRG 001, TAC versus FAC, which you'll be familiar with. The triple negatives in blue compared to, with given TAC versus FAC in red. And clearly in this cohort, the addition of the taxane yields an advantage, as was true for the overall trial. And then in a slightly more difficult to interpret trial from Lesh, there is a study where instead of cyclophosphamide, additional cycles of paclitaxel were used. And again, in the triple-negative cohort, it looks as though the addition of more versus less paclitaxel was associated with a benefit. These three data sets that I've just quickly run through all consistently suggest that in triple-negative disease, there is a taxane benefit. A newer agent, ixabepilone, has been studied for triple-negative breast cancer, either in subsets of randomized phase 3 and phase 2 studies. And like the other agents I've already touched upon, there is a signal of activity and I think great difficulty in assessing a relative value for this drug compared to others. The big story for a long time has been the platinum salts, and the reason for this has been their specific mechanism of action, which is that they, of course, complex and bind. They cause cross-link strand breaks, and this triggers, presumably, cell death, which triple-negative breast cancers, for reasons that Mark has just gone through, might be particularly vulnerable. But figuring out whether they actually have activity has been challenging. And for fun, I went back and looked at the history of platinum salts because I'm not sure how many in the audience have actually thought about this, but these are not old, they are ancient. Their history begins in the middle of the 19th century when Perron described what's called Perron salt, and Werner in the late 1800s then deduced the structure the way this was done in those days. In the 1960s, Rosenberg and Van Camp demonstrated using an electrolysis model to generate the platinums that E. coli division was inhibited. So what you end up with are megacells, gigantic E. coli when they're exposed to platinum. Clinical trials in cancer didn't begin until the early 1970s. The FDA approval was specifically in ovary cancer and testes in 1978, and then in 89, replacing cisplatin in many centers, carbo became available because while it forms similar cross breaks, it does not appear to be it appears to be cross-resistant in some cases with cisplatin, but not all. And there's an additional number of platinum agents that have subsequently been developed in the attempt to provide a greater therapeutic index. So the randomized data that we've had to address the role of platinums has been extremely limited. It's probably hard for you to read this slide. This is the meta-analysis that we've all read from the late 90s by Fassetti, and I highlight in red the single randomized trial for platinum. It is confounded. It's confounded because this study associated the cisplatin with doxorubicin on the left versus a non-doxorubicin containing regimen on the right, which also omitted the platinum. And I'm just making a point here that in this trial, the combination of these two good drugs, platinum and doxorubicin, was associated with a reduction in benefit, with a point estimate shown to your left. So this would not have been what you would hope to see for an exciting drug. The other randomized trial, which again is very small, epirubicin alone versus epirubicin and cisplatin in metastatic disease, does show at least a borderline advantage for the addition of platinum in a completely unselected cohort of 139 randomized patients. There have been a series recently of phase 2 studies, some of them pretty modest in size, others retrospective in the preoperative or metastatic setting using both carboplatin and cis confounded by the addition of other agents, and they continue to show pathologic complete response rates across the range that we see in other clinical trials. I want to highlight Silver and Judy Garber's particular study because it's gotten appropriately a fair bit of attention because it was prospectively conducted and enrolled a specifically defined cohort of triple-negative patients. So first pass, in the pre-op setting at Dana-Farber, 14 out of 28 patients given single-agent cisplatin responded, 6 of them with CRs. However, as is typical of a large eastern city in the United States. There was a relatively high incidence of BRCA mutation carriage in this patient population, and if you eliminate the 2 patients who were known to be BRCA mutation carriers, leaving behind the patients who were known not to have those mutations, the CR rate is 4 patients out of 26. That's a 15% CR rate to a single agent in a prospectively conducted study at a big cancer center. So that can be taken as impressive, but I draw your attention in contrast to a non-platinum containing regimen reported by Ian Smith, looking at something like CHOP, which was the anthracycline containing regimen pre-op, followed after 4 cycles by randomization in the responders to docetaxel or more of the CHOP. And in this case, there was about a 15% increment in the CR rate. So this suggests that CRs in triple-negative breast cancer, apart from the BRCA mutation subset, may not be particularly greater with platinums than they are with other regimens. And indeed, this has been seen as well in the MD Anderson series, where the CR rate was 27% for the paclitaxel FAC regimen, and that included the diluting effects of a large number of patients who had ER-positive disease. So, I don't think we have a clear answer in the unselected triple-negative population as to whether or not the platinums represent a special agent, and this is something, as I'll show you in a few more minutes, is still under careful study. The bevacizumab story is, to say the least, complicated for all comers and no clearer for the triple negatives. I would simply leave you with the message that across all of the thus far reported prospective clinical trials of bevacizumab, there is no clear signal that this anti-angiogenic has any special properties in the triple negative cohort than it has or doesn't have in the broader population as well. EGFR inhibition has been another interesting story, not on this slide, but oft forgotten, is that Andy Seidman in the 1990s gave cetuximab with paclitaxel and then with doxorubicin in breast cancer, and in that experience discovered that A, it caused an unacceptable acneiform rash for women with breast cancer, and it did not appear to have particular activity. In the TBCRC, Lisa Carey conducted a prospective study of single-agent cetuximab or the combination with carboplatin. The single-agent cetuximab was deemed not worthy of further study in this trial, and the combination was deemed possibly worthy of further study. But of course, this is simply a comparison of getting or not getting platinum. Whether or not the anti-EGFR antibody was contributing at all is pretty tough to say. In contrast, Joyce, who's going to speak next, presented a trial of irinotecan with carboplatin alone or with cetuximab, and in the triple-negative cohort was able to demonstrate an increase in activity for the antibody. There are a variety of other potential targets incompletely validated at this point in triple-negative breast cancer. You'll hear about some more of these in the course of the day. Others you will not. I just think you should pay attention in particular to the ones I've covered so far, to additional inhibitors of angiogenesis, to the SRC kinase story, which is unfolding with AZD0530, dasatinib, and other agents, and the checkpoint kinase inhibitors, and so on. I'm going to spend a little bit of time for a minute on the androgen receptor story because I think that that's one of that illustrates both the risks and benefits. I can't, of course, proceed without at least briefly touching again on the PARP inhibitor story. This is something that Mark has very nicely described for you already, and you'll hear again from Joyce, so I'm not going to spend time on the basic science. But I do want to highlight, and I mentioned this in my introduction a moment ago, the rapidity of the translation of Alan Ashworth's preclinical experiments into a meaningful clinical advance. And something that I have to say, Joyce, you kind of, as a joke, ruined for these investigators. Had you not had the BIPAR presentation as a plenary talk at ASCO last year, I dare say this would have been the big story at ASCO. And I want to therefore draw your attention to it for just a moment. So based upon the work that Mark so elegantly just reviewed for you, these investigators proposed that a PARP inhibitor would be especially useful as a single agent or maybe in combinations in patients who have BRCA mutations. And they accrued, I think, a very difficult to assemble cohort of patients with metastatic disease at multiple sites, extensively pretreated, a median of 3 prior systemic chemotherapy regimens. And these patients either had BRCA1 or 2 mutation status or an overwhelming family history consistent and suggestive of that mutation. And I draw your attention to 2 aspects of this trial. First, on the left is a low-dose cohort, which was based on the preclinical data suggesting that that dose would achieve a sufficient serum level for inhibition of the target. This may be a bit of a peril for us as we think about moving away from MTD-based dosing in drug development and towards known target inhibition. This dose was supposed to be effective at target inhibition, and if you only did the trial with the 100 milligram low dose, 27 patients, you would have been impressed in the salvage setting by a 22% response rate. But they also gave a higher than indicated dose, 400 milligrams, and in fact found a near doubling of response rate, 41%. I think you have to pause for a moment here. 41% response rate, single agent, relatively non-toxic oral therapy in the extensively pretreated patient population accrued is a remarkable observation. And this should have sent us off to the races in terms of drug approval. You see that the complete and partial response numbers are significant, and not shown on the slide is that the time to progression was about 2 months longer in this non-randomized intra-study comparison. This led them to actually drop the 100 milligram dose arm and allow some of the patients to cross over to the higher dose. The toxicity associated with this single agent was modest. If you look at any grades on the left and you look at grade 3 on the right, especially at the high dose, you still see single-digit percents. And I personally, anecdotally, can describe my patients who were on this study who, at progression, looking at their scans with clear evidence of enlarging tumors, nevertheless desperately went seeking second PARP inhibitor studies because they had never been treated with so non-toxic and effective a therapy. And this is both heartbreaking, but I think exciting in terms of what might be possible. This is as beautiful a translational story, in my opinion, as what we saw with trastuzumab and HER2 a decade or more earlier. So now I want to switch and focus on the androgen receptor. This could be subtitled, Everything Old is New Again. So in the way in which we took an old story and made it new, a pre-medical student, and he was not even a pre-med student at this time, he was actually an English literature major from college who came to work in William Gerald's laboratory at Memorial, processed 99 specimens that were on a TMA and did the usual cluster analysis that you've seen before. Shown in blue are the ER positives and shown in red are the ER negatives. And I draw your attention to a small sliver shown on of the specimens shown on the left, in which a number of the ER negatives by clustered analysis ended up lumped with the ER positives. And Ashley asked the question why. And without going through the interesting but I think arduous science involved, the standard approach to this kind of gene discovery work is the principal component analysis. And what this identified was that there were a series of additional genes that were upregulated here that were similar to what is seen in ER-positive breast cancer. But he painstakingly went back through these specimens and identified by mRNA and repeat IHC that they lacked ER. Shown on the left is this group, which is called Group A, and what actually defined them is that despite the lack of ER-PR negativity and this downstream expression analysis that suggested that they were in fact similar to ER positives, these patients, 50% at the time, had androgen receptor expression, and you see that in the upper right-hand portion of this. And that is in distinction to the patients who did not cluster this way, where there was only rarely the androgen receptor expressed. The role of the androgen receptor has been, I think, rediscovered in that regard. I actually remember quite well Mark presenting this data at University of Miami a little while back and having Mark Lippman appropriately point out that 20 years earlier, he and others had been talking about this, and it's very much true. I don't want to overstate this. AR is widely expressed, actually, in breast cancer. It's just not been a focus of interest. The difference here is we narrowed our search to the triple-negative cohorts, and the incidence of AR positivity in that subset is A, lower, but B, more important, because as you've already heard, there aren't a lot of proven effective non-toxic therapies for these cases. So to convert this into a clinically meaningful result, Tiffany Traina has taken work that Michael Danso, when he was a fellow, began, and converted this into a prospective clinical trial. The goal is to accrue 28 patients who are triple negative but AR positive and expose them to a widely available prostate cancer drug, the androgen receptor antagonist bicalutamide. It's cheap, it's available, it doesn't need phase 1, it's been around forever, and that's in fact what we're doing. The challenge for us has been the rarity of AR positivity in the clinic. In that TMA that I showed you, actually estimated 20% positivity in triple negatives. In the clinic, we are running 10% in the triple negatives. By the way, the rate of AR positivity in HER2 positives or ER positives might approach 30% or more, actually. So the drug development challenge here is highlighted, I think, wonderfully. If triple-negative breast cancer is 20% of the disease, and if 10% of that is AR positive, we are down to 2% of breast cancer. And were this a new target and you were developing a new drug, you can just imagine the business and regulatory challenges that you would face in trying to demonstrate efficacy and move this forward. We've taken this out to the Translational Breast Cancer Research Consortium so that we can actually get it done, because at this point we've screened over 80 patients and only identified about 12 with AR positivity, and only about 8 or 9 have gone on the study. That said, I'm in anecdotes here. We have at least one patient who's been on the bicalutamide more than a year, and several who have gone past 6 months. These are triple-negative breast cancer patients who would otherwise only be getting chemotherapy. So, finally, turning to the question of practice, are there guidelines that can specifically give you aid in deciding how to treat these patients in the clinic? And the short answer is no. The intermediate answer is a little bit. Both the St. Gallen provides a brief mention of triple negativity, and the NCCN is nonspecific but includes triple negative in its guidelines. Others are even less clear. There are therefore a variety of prospective trials ongoing to look at a range of therapeutic options for these patients, more than 61 trials listed currently on clinicaltrials.gov. And in a very selective fashion, I'm just highlighting a couple of these. There are clinical trials here testing ranges of chemotherapy. Beatrice, which is testing the activity of bevacizumab. There are trials in the metastatic setting looking at various chemotherapy combinations, and there are preoperative studies, including a factorial study that Bill Sykov from Rhode Island is chairing for the CLGB, that is prospectively evaluating both the role of carboplatin in a randomized fashion and bevacizumab as well with correlative science. So here's what I've tried to cover in my talk and leave you with, and that is that first, triple-negative breast cancer is clearly a distinct subtype looked at from the perspective of ER and HER2, but there may yet be subtypes, and the challenge that represents, I think I hope I've highlighted for you clearly. It is a surrogate of basal-like breast cancer. If your goal is to accrue patients with basal-like breast cancer, using ER/PR HER2 negativity gets you an approximation, but around the edges, as I described in my introduction and Mark highlighted again, you're going to have some noise, including some HER2 positives and some ER positives when you select for basals as opposed to triple negatives. And at present, we can't say that there is a proven effective single agent that targets a vulnerability in triple negative breast cancer, but as you can see from these bullet points, there are any number of potentials, and the next talk is going to highlight one in particular that Mark has laid the groundwork for. So thank you very much.